the chairperson, Dr. Usha Singh, is the professor, Advanced Eye Research Center, Postgraduate Institute of Chandigarh. Then we have two young moderators, Dr. Parul. Dr. Parul Ichpujani is the professor at Government Medical College at Chandigarh. And Dr. Shubham is an oculoplastic surgeon from Center for Sight, Hyderabad. Then we have another two very young panelists, Dr. Apurva Ayachit and Dr. Karan Bhatia, so who has joined us as panelists, and very renowned board of faculty, Madam Katie Singh and Dr. Sabyasachi Sengupta. So over to you, Dr. Shubham and Dr. Parul, and I request Dr. Shubham to kindly introduce Madam Katie Singh.
Good evening, everybody. Ma'am. Very good evening to everyone. We are on the 89th episode of this AIS ARC initiative. And as rightly said, we have two stalwarts in the field to speak to us today. One is Professor Dr. Kirti Singh. It is a matter of immense privilege for me to introduce Professor Kirti Singh. She is the director of the Guru Nanak Eye Center and director professor of ophthalmology at MAMC and Allied Services. She received a basic medical education from the Lady Hardinge Medical College and post-graduation from the prestigious RP Center, AIMS, New Delhi. She's a fellowship in glaucoma from the Wills Eye Institute and also has to accredit international fellowship in the medical education in 2016 and a diploma in the hospital management. Needless to say, she has many honors and awards to her name, few of which are listed here, and I should run through the list. National Ophthalmic Lead Educational Weekly Webinars and the NBA Standardized Postgraduate Training since January 2021. She has been active part of it. State Program Office, National Program for Control of Blindness, 21 to 23. Honorary Faculty for the Medical Education Department, MAMC. Honorary Faculty for the Microsurgical Skill Training, MAMC, and the recipient of the FICCI Award for Surgical Innovations. Honorary Faculty, Occupational Environmental Health and Clinical Epidemiological Unit of MAMC, and Delhi Ophthalmic Society positions as the editor and the treasurers and provost for MAMC. Also to the list to add are the awards, which include the Commonwealth Fellowship in 1999-2000, the Moorfields Hospital, London, the WHO Fellowship 2009, Low Vision Rehabilitation in the Arvind Eye Hospital, Dr. MC Agarwal Trophy for DOS 2020, and was selected for the Colonel Rangachari session in the All India Ophthalmic Society. She has multiple awards for the best papers, videos, posters at AIS and also the DOS, and named orations, Dr. B.N. Khanna in 2019, S.N. Mehta 2020, and Dr. Harimohan Oration in 2021. She also is a recipient of the IRSSI 2019, the Uttarakhand Ophthalmic Society in 22, and 5 gold medals, including the Student of the Year in the MBBS, with distinguished teacher awards over the years. Few publications which are listed here and many more that she has been an active research part include the 4 textbooks in glaucoma and contact lens, chapters in 15 books, 100 indexed and peer-reviewed publications, and has delivered staggering over 800 educational lectures, the various CMEs at local, state, and international level meets, authored a volume on English poetry, and is key to many new initiatives at her institute of work. Over to Professor Kirti Singh for today's talk.
Thank you very much. Am I audible?
Yes,
Yes, ma'am.
Thank you very much for that kind introduction, and thank you very much for having me here, AIOS. So without further ado, I'll start sharing screen. So the topic given to me was formulating a research question and hypothesis testing. And that's the basic foundation of your any research is formulating a research question. So what is a research question? A research question is an uncertainty in the population the investigator wishes to resolve. It is written as a question. So you have a query, basically. Now, how do you develop that research question? You have to know the field and literature well. What are the important research questions already studied in this field? Could this study fill a gap? Is there any prior study? Would my study give additional information? This is how you build up your research question by doing this, and that's what we call the review of the literature. on the developing a research question further, wherever possible, we try to see that are we in sync with the current mood? Right question, right time. Example, a new medicine, a surgical modification, or a test like this study on the global increase of antibiotic consumption is very much in sync with the requirement of the world. So the publication chance is more, the impact is more if we have this research question. The COVID, the IGO and all the other journals took it up so fast when you had anything on COVID, because that was a new thing which was required. Another aspect is not only the novelty or in sync, but does it have a societal perspective? Are they going to be useful? Like, for example, this beautiful ice stupa, if you know the gentleman, Sonam Wangchuk. This is not related to medicine, but ultimately he saved lives and the livelihoods of so many people just by this research, innovative research in which he did a lot of work on using the water resources of the place he lived to create water annually. When you frame your research question, once you have done the review of literature and understood what you want to ask about and is it relevant, then try to write down, very simply sit down on the writing board and write down the research question as completely as possible in your own words. And then divide your question into concepts. For example, we all love to take in photographs. We have taken this picture of the caves. And if you see, it's a wide angle picture. So your research question, supposing it is too wide, then in that situation, you would need to narrow it down to couple of 1 or 2 concepts or 2 or 3 concepts at the max. So remember this, that you just have to maybe zoom in and study that in detail, because that only would be feasible. Again, let's come to the type of research. Like you may have a thesis, you are postgraduates, you have a thesis which is a requirement for MS and DNB, or you would have an ICMR project, you want to carry it on for longer, or you have a cohort study which would be very long. But in all the studies, you have something called as the PICOT criteria as the essential elements of the research question. The PICOT is a mnemonic. P stands for the population which has to be studied. I stands for intervention or exposure which has to be investigated. C is the comparator or the control. O is the outcome of interest. And T is the time frame. So let's see what this PICOT means. Example, you have this research question which I want to study. Changes in iris parameters on anterior segment ocular coherence tomography in eyes with angle closure glaucoma post-iridotomy after lens surgery. So what is my research question? What is the rationale? I want to study changes in iris parameters, only iris. So I'm limiting myself to iris parameters. What is the population? Angle closure glaucoma patients post-iridotomy. And what is the intervention? I am doing lens surgery only. The population was they've had an iridotomy, their angle closure glaucoma. I am doing lens surgery. And what is the comparator? Vis-a-vis age-matched cataract cases. In those patients also, we are doing lens surgery. So that's the control or the comparator. What is the outcome of interest? Changes in the iris parameters. So the essential elements, just to repeat, are the PICOT criteria, population, intervention, and comparator, control, outcome of interest, time frame. So your research question must have these PICOT criteria. In addition, this was a beautiful fungus which I saw growing. And you all know how a beautiful fungus by Sir Alexander Fleming came to become the first antibiotic of the world, which was penicillin. So because he just understood, or he at least realized the importance of that fungus which killed the bacteria around. So getting back to the research question criteria, it has to be finer criteria. What is finer? Finer is feasible, I is interesting, N is novel, E is ethical, and R is relevant. So what does this mean? Feasible. Your research question, for example, let's go back to the same patients of angle closure glaucoma post-iridotomy. Do you have adequate subjects? Do you have ASOCT? Do you have the adequate technical expertise? Do you have an operator for the ASOCT? Can you afford to do this in time and money? Supposing you need to hire an operator or you want to do it yourself, you are a surgeon, you are a clinician, and you want to do this research, can you do it in the time which is required? And is it manageable in scope? Can you do it in addition to what all you are doing? Now, you will ask, what is this? You have to do it. If you do research, you have to do it. But if you look at the feasible criteria, in that situation, if you keep a um, uh, um, check on the feasible criteria, your research will be possible easily. Second is the final criteria was the interesting or novel. Novel or interesting would be it can confirm previous findings. Many of the researches are research, or it may refute the prior findings. For example, we had a study on viscocanal colostomy long back before the mix came in, and that study could never be repeated again. So most of the authors refuted the findings of viscocanal colostomy, and some of the initial ones did confirm. So that gives it a different dimension. Or you can extend your previous finding, or you can provide new findings, because each time it is not possible that all the research questions will be Nobel Prize winning new novel research questions. So you could just extend the previous findings, you can confirm the previous finding or new findings. And I wish we had a novel research question where we could regrow the optic nerve just like this arm is being regrown. But that's not always possible. Then you have something called as ethical. The IE is for ethical. We all know Declaration of Helsinki. We always say it conformed to the Declaration of Helsinki. Why Helsinki? Because in 1964, the World Medical Association policy statement of medical research ethics was in Helsinki. And that talked about informed decisions where the participants' welfare would take precedence over science and society, which was not the case previously, and with a special vigilance to this. What was the genesis of this ethical Helsinki Code? Because of the Nuremberg trials. If you may remember, post-Nazi World War II, there were a lot of war crime tribunals, and Nuremberg Code came out because of most of these medical tests or the medical procedures or the experimental procedures were done for these things, for these subjects who were Jews, and in Vietnam, they were done on the Viet Cong. So because of the Nuremberg Code, the Helsinki came up that you have to have the participants' welfare take precedence over science and society. That is why in all your research papers, you will have the informed consent papers. You will have the informed consent in vernacular language as well as in the English language or Hindi, whatever is required. Let me just tell you a small story of where this was not considered. You all remember the first successful vaccination of smallpox. The story was Edward Jenner. In 1796, he inoculated James Phipps, an 8-year-old boy who was the son of his gardener, from pus of cowpox blisters of milkmaid, because he was convinced that the milkmaids don't get smallpox because they have these smaller, milder cowpox. Now, this child developed fever, uneasiness, and no full-blown infection. But later he injected Phipps with the variolous material and he had no disease. So his first paper was only on 23 cases. So you would say he did not follow the participants' welfare taking precedence. But his intention was good. But at the current time, you cannot say that. You will have to take all the consents. Incidentally, in that paper of his, which had 23 cases, Edward Jenner included his own 11-month 11-month-old son, Robert. So it is not only the son of his gardener, his own child be included because he believed in this vaccine and his belief was right. So by this story, I wish to just keep it in your mind that the Nuremberg Code started the issue of ethics, and we must keep the ethical aspect in our mind when we design any research question, especially if it is surgical intervention or a new drug trial or something which is not the standard operating protocol or the SOP. Now, a good research question has further criteria. It should be relevant. For example, if you say smoking contributes to cerebrovascular accidents, it's relevant. But if you say smoking contributes to refractive errors, now you have to look for it. So you have to have the research question should be relevant and just not out of the box unnecessary question. So repeating, we had the Picard criteria for hypothesis and we have the finer criteria for the research question. Now, once you have designed the research question, the research question itself will determine your study design. For example, if you have the research question, I want to study the low birth weight patients, children born in the nursery in the next 6 months, then you have to do a survey. If you wish to have risk factors for cerebral palsy, you would need to do a cohort study and that would require a lot of time, or a case control design. Again, lot of time is required. If you wish to study effect of methylprednisolone in preventing recurrence of optic neuritis, as the ONTT trial was, you have to do a clinical trial. So a research question, when you write it down in words, it will determine your study design. So this is the most of the study designs. That's a whole topic in itself. So whether it's an experimental study, it's an observational study would have a comparison. It could be analytic or descriptive study. Then you have a randomized controlled trial or you have a non-randomized controlled trial where the exposure is before the outcome. You have the cohort study where the outcome comes and then the exposure is studied. That's a case control study, and cross-sectional is the exposure and outcome are studied simultaneously. So that's a whole topic in itself. So I'm just trying to give you this slide showing that your research question will determine your study design. Now, there are many problems. It's not easy to do research. Why? As I showed you in that picture, when you have a very wide research question, you've done a lot, you want to do this, A, B, C, D, E. It is too broad. Specify lesser variables, narrow down the question. You may not have enough subjects of the angle closure lymphoma in your clinic. Then you expand the inclusion criteria or modify the exclusion criteria, or you lengthen the study time, or you request a fellow of doctors to help you out and send you patients. The methods are beyond the skill of investigator. You don't know how to do ASOCT. You collaborate or learn the skills. It's too expensive. Then you have fewer subjects or measurements, less expensive measurements, or fewer follow-ups. Now, this is not true for a machine which you already have bought, but for laboratory tests, it's important. If it is not interesting or relevant, modify the research question. If it is uncertain ethical suitability, you have to modify it before the institutional review board kicks it out of the table. So if it is too expensive, you have fewer subject measurements, not interesting, consult. And this picture I especially show you because your research question, ethical aspects have to be measured, have to be taken care of much before you put it on the table. Now, the second rung of a research question is to transform it into an operational analog. You made the research question, you have the Picard criteria, you have the final criteria and position, you looked at everything, now you make it into a hypothesis. You formulate the null hypothesis. We'll come to what that is. Then formulate the alternate hypothesis. Then choose the appropriate test and compute the test statistics and compare with the theoretical values for the statistical significance, because without statistical significance, none of the papers are any relevance in today's world. So let's come to the null hypothesis. Null hypothesis means H0. That H0 is, let's say, iris changes post-lens surgery would be similar to the ones seen in the control group. There would be no difference. Whereas alternate hypothesis means there may be more changes than the control group or less changes. It could be less or more. By generating the null hypothesis and the test of statistical significance, the reliability of the test and how probable that the difference between observed and expected results on basis of hypothesis have been reduced by chance alone. So statistics just eliminates the chance or the serendipity observations. Again, there is nothing wrong with serendipity. Penicillin was a serendipity, so was smallpox, so was scurvy and vitamin C discovery of lemons. So it's not that serendipity has no role, but when you are formulating a research question, you cannot account for that in your paper. Now, another thing which can be added is the Picot criteria in the hypothesis is magnitude of effect. So to Picot, it is Picot M. What is M? Example, my research question is, my rationale is that does phacoemulsification cause a lowering of IOP period? Just a lowering of IOP in glaucoma patients. Little vague. Hypothesis is there. The research question is there. The hypothesis is open angle glaucoma patient. So I have specified the population, controlled medically. Clear corneal phacoemulsification, which is the intervention, reduces the IOP, which is the outcome, by less than 10%, which is the magnitude over a time span of 12 months. Why do you say 10%? Because your review of literature has told you that mostly in the studies before, it has been less than 10% or equal to. Therefore, you want to keep that as the guide mark, and your sample size calculation would be based on this. Moment you put the magnitude in, your sample size calculation for any research would be based on the Picot M, okay, magnitude. So the hypothesis, let's come back to it now. PIOM, Picot, and MT is the time frame. So I have tried to keep the things till 20 minutes. As a professor, I have a habit of, all of us have a habit of speaking without letting the students ask questions. So this is just a picture of any guesses, anyone? This is the journey or the transformation of a hypothesis, research question to a hypothesis and a fully published paper. It is a sunflower, how it evolves from a bud to a proper sunflower. Thank you very much. Open to questions.
Thank you, ma'am. It was a very beautifully exemplified talk, and I think that would drive in the concept to our residents very clearly.
Can I stop sharing? Or...
Yes, ma'am.
Okay, thanks. Yeah.
As of now, there are no questions in the chat box.
No, Dr. Singh has a question.
You're muted, ma'am. You're muted.
Okay. So, Dr. Kirti, it is said that either you make a research question at the beginning or a hypothesis, but not two together. Or how's it? I mean, can we do everything together?
No, ma'am. You should go step. If you remember, I showed the picture of the rung, operational rung. First you make the research question, then you put the Picot criteria into it, and then you go ahead and make the hypothesis, and then the null hypothesis is evident. You make the alternate hypothesis depending on what the previous studies till now or your own experiential learning, which you haven't published yet, tells you. So it is sequential, ma'am.
It is sequential, not simultaneous. Yes. Thank you.
I have a suggestion for all the young postgraduates who are listening to this is to read the latest revision of the Declaration of Helsinki, which is there on the World Medical Association website. There have been a lot of elements that have been added as regards the addressing the patients instead of subjects. They are now to be called as participants, and a lot of other elements in relation to confidentiality and even they have added the environmental sustainability. So rather than just writing down that the study conforms to the tenets of Declaration of Helsinki, I think all the students and rather each one of us should just read the Declaration of Helsinki, because that really would add insight to the hypothesis creation which we would be doing. Dr. Purva, any suggestions or inputs from your end?
Yes, ma'am. Actually, I want to ask each of the mentors here. I'm sure all of you have mentored several postgraduates over so many decades. I want to ask you, what is your opinion? Like, when a fresh postgraduate enters in first year, we put the onus on them to find out what is happening in that particular topic and come to us. And most of them don't even know how to access literature. They don't even know how to look for papers. And they don't, and to ask them to find out what is not being done is a little they're very way out of their range. It's very unfair to them to find out what's not being done and put the onus. What is your process? I mean, do you give them a ready-made topic, or do you want to make them do some work? What is your process?
That's a very pertinent question, Apurva. That what I do first, I asked a resident, like, you were interested in which specialty, like glaucoma, cornea, cataract, whatever from my MBBS knowledge. Then,
Hmm.
based on this, I asked her to read the latest journal and to get some articles related to that specialty. Then I sit with them and I try to find out that what is the scientific gap in every thesis that I gave. I try to first question that whether this research question will address any scientific gap. So based on that only, that is how I give the thesis. So, and interestingly, something really new comes up, and I have seen it in past so many years. Like, these are the theses who are getting some award because something new has come up. So I want to basically address, and I always tell them that it should be something very simple, but definitely which will add more, which will give more inputs to a scientific literature. So that is what I do. But I want to hear from others also, like especially in government medical college, how do you all address? This is a very pertinent question that she has.
Yeah. So actually, when the students come to us, they are just I would say, the MCQ children who have just cracked MCQs, and they really do not know the literature that well. They would just know the MCQ parts. So I initially, when they come within 1 month, initially they have the foundation course and everything. Then second month, since they come to our specialty in a government institute, we have the specialty already decided. So like mine is glaucoma, somebody would have gone, yeah. So like Dr. Kasturi, whatever is as I said in the very beginning, it has to be in sync with the current climate of the world, what is needed, what has a societal perspective. And as Parul said, the environmental impact of is it all those, in my mind already we have 5-6 aspects, and you give this bouquet to the student, and this is the options available. Are you comfortable doing, example, if you may have an animal research, is it feasible or not? You may have a patient research, you may have a research like I had last time, a thesis with the gynecological obstetric patients, the IOP in pregnancy. So I asked the student, are you comfortable in going in the gynae ward and the obstetrics ward? He says, yes, ma'am, I would love it to do something new. So that way you just give that options. And then somewhere all the time you can't, Apurva, there's also an issue. You have a limited amount of things which can fit the final criteria. Because time is a problem in any postgraduate. They only have 1 year with us. So keeping that in mind, you give them the relevant options, and then probably the students will choose from them which suits them the best. That's how we do it. I do it.
Usha, ma'am?
Yes, I agree that most of the students who join the PG course, they are MCQ students. But once in a while, we do get patients we do get candidates who are very clear on their mind what they want to do. I mean, they would have done their background work. For example, we had a resident who had already read up about ROP, and he knew what he wanted to do. He knew under whom he wanted to do what topic that's on ROP. So today he's a leading ROP person. That is Dr. Anand Vinekar. You must have heard about him. In the very first year, he knew what he wanted to do. But now there is a very different situation in PGI. Now there is a circular, there's an order from the director that says that let the student decide his thesis guide. So now this brings in too much of complexities into it. Which topic they want to do, which is easy, who is the easier guide to do. So there are so many other things. But initially it wasn't like that. We used to, whichever clinic they were posted, they were said, okay, you are under this faculty. So then that faculty would say, just do some background reading and then come back. And so that you start understanding what the subject is. And then, of course, the faculty gives the topic. That's how it was. But now things are slightly different in PGI. So new students, they come, they just choose their own guide. I don't know what guides them to choose which guide. That I don't know.
And if everybody chooses Dr. Usha Singh, then what happens, ma'am?
True. That's what I'm saying. Some esteemed professors will have 4 or 5 students under them. Some professors will not have any PG candidates. So there is so much of I don't know if it's a good thing or a bad thing, but some things are coming forward now. Maybe it needs a lot of discussion on these aspects. And the topic, of course, topic of thesis comes later. And I don't know what guides them, what motivates them.
The seniors. The seniors will, the immediate seniors must be the one who are guiding them. But Usha, I think there is a rule for one session, one professor can be a guide for 2 students.
3. You can be for 3. Professor can be for 3. Associate professor for 2. And only after 8 years, an assistant professor can become associate and then the guide. So 3. Currently, I have 6 postgraduate students with me. 1 of the last year and 1 of the 3 of this year. So we can have up to 3.
Yeah. So to put your question into a final nutshell, Apurva, I think if the professor has been working on some concept or they have something in mind, they can make a short list of 4 or 5 topics, give the resident these topics to read, and based upon their inclination and the feasibility of the institute, the topics can be given. But somewhere the faculty has to help the candidate into, shortlisting the topics, because otherwise it'll just be like a wild goose chase. So there are a lot of aspects to be discussed, but without much ado, we will move on to the next talk of this session. And I request Dr. Subhav to please talk about today's second speaker.
Thank you so very much, ma'am. It's a pleasure to introduce Dr. Sabyasachi Sengupta, fondly known as Sunny Sengupta. He is a veterinary surgeon practicing at the Future Vision Eye Care in Mumbai, with his areas of interest in research methodology, retinal diseases, and currently fitness. He has his training from JIPMER, where he finished his diploma in ophthalmology and received his diplomate in National Board from Arvind Pondicherry. He's a research cum clinical fellowship in Vitreretina from Shankar Netralaya and a research fellowship from the prestigious Wilma Eye Institute at Johns Hopkins. He's a recipient of Dr. G. Venkataswamy Gold Medal in DNB in the year 2009. To his credit, is the first ever non-British to be awarded the McCartney Prize by the Royal College of Ophthalmologists in London. He's included in the top 2% global researchers with Stanford University in the year 21 and 23. Has published 130 plus research papers in indexed peer-reviewed journals, is the founder of the very famous, more prominent Sengupta's Research Academy, a one-of-a-kind portal offering e-learning on research methodology and services for manuscript preparation. And undoubtedly, he is a prolific speaker on research methodology, retinal diseases, and fitness across national platforms. Over to you, sir, for tonight's talk.
Thank you, Dr. Shubhav, and very good evening, everyone. So let me quickly share my slides. So I've been given the more difficult topic of speaking to you about biostatistics. And, it all sounds pretty difficult, but then trust me, it is easier than making a tunnel for your first SICS case. Right? So let me try and simplify it to you as much as I can. I think Shubham has already introduced me. So, Sengupta Research Academy has been training a lot of students from all over the world, and this is a quick, footprint of the academy on the world map. And we have a lot of students. There are actually more than 700 ophthalmologists in India have trained in research techniques. So, hope some of you are listening to this lecture as well. Some of my financial disclosures, though, I don't think anything is, particularly pertinent for this talk. So with the previous talk from Kirti ma'am, I think the Josh is pretty high, and we are ready to delve into something new. I would start with just because most of the listeners would be postgraduate students. I think you need to understand, and so a lot of people will bring in Rancho, right, from Three Idiots in their presentations, and so what he says is, "Bacha काबिल बनो काबिल, कामयाबी आपके पीछे भागेगी," right? So so the whole concept is to chase excellence, and then that success will follow, right? So put in that time, put in that effort, and learn these techniques. Trust me, this is going to be much more fruitful even as soon as 2030 comes. That's because when a lot of things are going to get automated, and a lot of questions are going to be raised from data. Right. So if there is a large company who is doing a lot of AI-based work, and we are actually using it in clinics, and they may actually come and ask you, Doc, from the last 1,000 cases, how can my machine improve in predicting so-and-so disease? And then you will say, okay, show me some case files. But they'll say, oops, I don't have case files. I'll give you an Excel sheet. The Excel sheet will have like maybe 7,000 rows and like 1,000 columns. So looking at that, then they'll tell you, okay, for this work, I'll reward you, like I'll give you like whatever sum you want. But then are you in a position to extract that information from that Excel sheet and give them that juice? And that will come when you know something about statistics, right? And also something about research and how they're gathering data. So, trust me, it is going to be even more important than making that SICS tunnel that I talked about even before. And a lot of times I hear people say, oh, I'm busy, I don't have the time. But what I actually hear is, oh, that intent is missing. Perhaps the drive is missing, So, so work on that intent, work on the drive, and you will see that, nothing is really difficult because there is so much potential, right? Remember, data is power, and it is currency by 2030. And by the time you are into clinics and practicing, data is going to be everything. How much can you leverage data and produce results which will be uplifting for a lot of people around the world, right? So unless you know some basics of statistics, you'll not be able to utilize your own data, right? So people say, oh, we are sitting on a stockpile. If data were nuclear weapons, India would be the richest in the world. But then unfortunately, we haven't harnessed that data into any actionables, right? So whenever you have the time, and this is going to be, I think, on YouTube, so you can look at this quiz, take this quiz, and try and understand how much you already know. And then maybe you can take this quiz even after watching this session, and then understand how much you've gained. Right. So what we're really talking about is data analysis and interpretation. And let me just, so remember that we need to visualize that data. From an Excel, that whole thing goes through a journey. Like we saw a beautiful flower in the previous presentation where paper goes through a different pipeline, right? So similarly, the data also goes through a whole pipeline where it initially goes into Excel because you enter it into the Excel. And then there are many different formats, but Excel is the primary format that we use. Then that data then enters into a blind tunnel, which you can't see. And that's called a statistical software package, which is in the domain of the statistician. then he's going to export something out and send it back to you, which you may not be able to interpret at all. It'll be like a 50, 60 page Word document with very small fine print. And you're like, oops, what am I supposed to do with this? Right? Then from that, you need to then make tables, figures, the text of the result section. So the data is really going through a whole conduit from the patient's file, maybe, or from the actual execution of the study to the Excel sheet, and then into a software package, and then into the result section in the form of tables, figures, and text. Right? So how do you actually do this? Is something which will take a lot more time, but I'm going to try and give you a little screenshot of what this might look like. So overall, this is the publishing map where you plan and execute the study, you write and analyze, write the paper, and then you submit it to a journal and get published. So overall, this is the pipeline where you have an idea, then you have a design, then you execute, analyze, and you write. And what we are talking about today is only a snapshot of the analysis, whereas Kirti has talked to you about the design. Right, so I'm going to show you only 2 sentences, and we are going to try and see what is at the back end of this. And by that, you will understand a lot about statistics, right? The first sentence, which you will commonly see in a lot of publications, so this is from a retinal disease perspective. So this is the CMT, or central macular thickness, reduced from 480 plus or minus 130 microns to 320 plus or minus 80 microns with aflibercept, which is an anti-VEGF agent, and then 489 plus or minus 140 microns to 340 plus or minus 90 microns with ranibizumab, which is also another anti-VEGF agent for, say, diabetic macular edema at 3 months follow-up. So the one in red is pre and post for aflibercept. The one in blue is pre and post for ranibizumab. So you could, instead of CMT, you could take intraocular pressure, say 35 plus or minus 15 pre, and then maybe 18 plus or minus whatever post. Similarly, ranibizumab, or say with one drug of glaucoma and with another drug of glaucoma, or say one type of surgery versus a new mixed kind of surgery, right? So you will see these sentences across the board. Instead of CMD, you could have any other kind of variable, right? And then the sentence says reduction in macular thickness in the 2 groups was comparable without any statistical significance. P is 0.63, right? So if you actually have read some papers, you will realize that this is a very common occurrence, and any paper without these kind of sentences will not go through, right? So then, what is at the back end of this is what we are going to try and understand. The other is going to be about causality. So let's take another example. So if someone compares the lipid profile of 50 patients with glaucoma and 50 age-matched controls, right? So if you are not able to follow, you can pause this maybe even later on and go through this. So if someone compares lipid profile of 50 patients with glaucoma and 50 age-matched controls, and shows that 60% of these glaucoma patients and 15% of these controls have dyslipidemia, that p-value is significant, p is 0.03, that is 60% is far more than 15%. Can you conclude that dyslipidemia is a risk factor for glaucoma? Right? So in other words, is dyslipidemia associated with an increased risk of glaucoma? Right? So when you think about this, you will realize that, here we are starting with glaucoma and without glaucoma. And, and then we are actually seeing how many have dyslipidemia. Right? So these numbers actually have been bumped up a lot more, but this is a study which has been published in IGO. Right? However, when which comes first and which comes second is what your brain needs to think. So first will come, dyslipidemia will come first. So the risk factor will come first, and then that outcome will come, right? So the ideal way would have been to start with a group of patients with dyslipidemia and without dyslipidemia, be age matched, and then follow them up over a period of time, whatever, 2 years, 3 years, 5 years, and then see actually how many developed glaucoma and how many did not develop glaucoma. That is when you can really say dyslipidemia is a risk factor for glaucoma, right? So, so again, there are many different ways of doing the same thing, but overall, so this is a question about study design. However, the statistics involved is this percentage. Previously, it was not percentage, it was plus minus, so it was, so I'll talk about that, but overall, this is about percentages. So 60% is far more than 15%. We're talking about percentages, and what is this p-value? So let's dive into these concepts and try and understand these sentences. So this is an ebook. This is a QR code for an ebook, which whatever I'm going to say next is going to be part of this ebook. So you can download this whenever you have the time. So before we understand these, we need to understand some basics, some rules. If you want to drive a car, and you don't know what the green and the red signal says, you can't start driving. Even if you know change in gears and speed limits and all that, without knowing the signal, you can't go ahead drive. Similarly, even if you have some idea about these sentences, you need to understand some basic rules of statistics. So the main rule is, what is a variable? So it is a set of observations in data, and really every column in your Excel is a variable. Right, so usually we will put every patient or every eye in ophthalmology as a separate row, and then everything that we're measuring is going to be a column, like age, gender, vision, thickness, etc. So every column in the Excel is really a variable. So there are two types of variables mainly. One is a continuous variable and one is a categorical variable. Right. So what is a continuous, what is a categorical? And it's really important to differentiate these. So continuous, also called as quantitative, it's a you can actually quantify it. It's a variable that can take many different values from the lowest to the highest point in measuring on a measurement scale, right? Like macular thickness, or like intraocular pressure, or like BCVA. So these are all examples of quantitative variables, right? So it could have, say intraocular pressure varies from even sometimes 0 to like 70, or say macular thickness can vary from a thin macula, which is 130, 140 microns, to a very edematous macula, which is like 800, 900 microns, right? So it could take any value between these two. Remember, it will always have a unit to it. Like intraocular pressure is in millimeters mercury. Macular thickness or RNFL thickness is in microns. BCVA is in logmar, right? So these are all examples of continuous variables. Once we look at continuous, then we see what is a categorical variable. So category is quality. As the name suggests, categories, right? You are putting these into baskets or into something which they are grouped because of the common property, right? So this is not from the lowest to the highest scale, because you can have only 2 or 3 or maybe 5 categories of it, right? So example is gender, male and female. And nowadays you can have like, undisclosed or don't want to disclose and all of that. Success could be yes, no, or it could be partial, it could be complete, or all of that. Types of macular hole closure is type 1 or type 2 closure. There can't be any more than that. Type of neovascular membranes can be either classic or occult. So type of injection used, Avastin, Lucentis, IVT, whatever. Types of eye injury, either open globe or closed globe. So these are, as you'll realize, these are all percentages, right? So how many had open globe out of your total study, right? So that is an example of a categorical variable where you don't have a unit to it. You will have a percentage to that number. So categories can be either 2 or more than 2. If you have 2 categories, it's called binominal, as the word suggests, bi. That's 2. If you have more than 2, and it's possible, right? You will have more than 2 sometimes, and there is an order to it. Say for example, complete success, qualified success, and failure is commonly used in glaucoma studies, or commonly we say mild NPDR, moderate NPDR, severe NPDR, and so on, right? So diabetic retinopathy grading is an example of an ordinal variable. So that's more than 2 categories and there is an order to it. And the third is multinominal, where there is no order to it. That, like say number of or type of injections. Right? So there is no order to it, and this is called a multinominal. So again, for quick, we don't have a lot of time, but you can do this, gradually and pause it and do it later on. But so height of retinal, subretinal fluid in CSR is going to be in microns. That's a continuous variable. Presence or absence of hard exudates in DME. Now this is yes or no. This is a binominal categorical response to IVTA. It's, you could say it's good, fair, and poor. So this is an example of an ordinal variable. Number of days of follow-up of patient. Of course, this is in, it could be like 1 or 2 days to like 2 or 3 years. This is an example of a continuous variable. So, how do you put all of these variables into Excel is also something which is very important. And, this QR code will take you to that, making the Excel sheet. Once you have that Excel sheet, what do you do with it? So we first talk about descriptive statistics, where we talk about one column at a time. Remember this, each variable in your Excel is a, each column in your Excel is a variable. So we talk about one variable at a time. So for example, when a cricket match is happening, a player comes out to bat or to bowl, they'll show you their characteristics first. Oh, his name is Rohit Sharma. He has scored so many centuries and all of that. Right. So they describe that person, that individual, and then all of them start playing together and then they interact with each other. So that is called analytic statistics. But first and foremost, what you want to do is describe each variable right? So it's almost like humanizing that variable, So, Mr. Age will come ahead and say, oh, hello, my name is Mr. Age, and these are my characteristics. Then, Mr. Gender will come in, or whatever, Miss Gender will come in, So each variable will be described separately first, and then they will start interacting. So how do you describe these variables? So a continuous variable is described by using either mean with standard deviation, median with interquartile range. So mean, as you all know, is an average, and standard deviation you all understand. Median is when say we're talking about age, you arrange people from the lowest to the highest age in your study, and then whoever is in the central part, one or two values, that is the median value, right? So if it could be one or two values based on whether there are odd or even number of participants in your study. Interquartile range means so the median is basically the 50th percentile, that is the central one. Then you can have the 25th and the 75th percentile, right? So the lower value and the higher value, right? So based on that, between the 25th and 75th percentile, that's called IQR. Range, of course, is the lowest to the highest. And then it is best shown using box and whisker plots. And I'll show you what outliers are. So, this is represented using box and whisker plots. Then the categoricals is relatively simple. It's just proportions or percentages. So how many percent men, or like I said before, how many percent open lobe injuries and things like that. And it's best shown using bar diagrams. So this is an example of a box and whisker plot. This is intraocular pressure at baseline or preoperatively, intraocular pressure at 6 weeks, intraocular pressure at last visit. So if you see, this is a box and whisker plot. The central box, in that the central line is a 50th percentile, the lower line is a 25th percentile, the upper line is a 75th percentile. These whiskers, this is a box. The whisker means nothing but the mustaches of the lions and tigers, right? So of large cats. So these are the whiskers. This is the 90th percentile and this is the 10th percentile. And then these are values which are far away from the median. These are called outliers, right? So the median value of intraocular pressure before surgery in this was somewhere around 18 millimeters mercury. But then there were some who had 55, 57 millimeters mercury, and then also some who had 39, 40 millimeters mercury, and maybe somebody who had a zero intraocular pressure as well, right? So when you see this, you will realize, oops, this is not right. So who is this person? Why is it zero? And then actually we realized when we go back, I realized that, this was actually not zero, it was 30. And the person, entering had entered 30, but somehow that 3 did not come up. So it was just left as zero. Right, so this will tell you a lot about that continuous variable. Right, so it will tell you if there are data entry errors. It will tell you if there are outliers. What do you do with these outliers? Do you want to keep them or do you want to discard them? Sometimes there are data entry errors and that will change. Right, if you want to discard them, remember that your data set is becoming less variable, and therefore it is applicable to a lesser audience or relatively lesser group of patients, right? So don't throw away outliers, but at least know that they are there and try and see how much influence they are having on the final outcomes. There's a more complex box and whisker plot which can be made using R, but the idea is the same, where you show the median, the interquartile range, and the 19th and the 10th percentile. Let's look at analytic statistics. When people start playing, the cricketers start playing, they interact with each other, and one will win and one will lose. So now they are going to interact with each other. First thing that they can have in terms of analytics is differences between variables. Second is correlation between variables, and third is association between variables. So difference. So when we take examples, you'll realize so difference between variables in terms of groups, whether there are one groups or two groups. I'll tell you more in detail. So this is how that difference between variables is used for analysis. If it's a continuous variable, that means there is a mean and standard deviation to it. Let's take intraocular pressure, for example. If you are comparing across two groups, say trabeculectomy versus a mixed surgery, right? That is a minimally invasive glaucoma surgery or any new kind of glaucoma surgery. So you want to calculate the intraocular pressure before the surgery and then maybe at 1 month, 3 months, 1 year, or whatever. So when you want to compare across two groups, and that variable is normally distributed, that means there are not too many outliers. That means the standard deviation is relatively small compared to the mean. So usually it will be standard deviation less than half the mean. So if it's intraocular pressure of 30, then standard deviation should be less than 15. So if you have 30 plus or minus 8, it's likely to be normally distributed. If you have it as 30 plus or minus 20, that is standard deviation is more than half the mean, half is 15, right? So if you have a large standard deviation, that means there's a lot of deviation, isn't it? Standard, that word deviation means that there is a lot of deviation. That means, there are values which are outliers and they're pulling that mean towards themselves, right? So that is a not normal distribution, or it's called a non-parametric distribution. So when you have a normal distribution, we use the student t-test. When you have a not so normal distribution, we use the Wilcoxon rank sum test to find differences between continuous variables when there are two groups. If there are more than two groups, we use the test called ANOVA, that is analysis of variance, right? So, a lot of students ask me, oh, how are you going to analyze? Are you going to use ANOVA for the analysis? I was like, you only have two groups, so there is no question about using ANOVA, right? So that's a very basic question, but this graph will give you a good idea of what test to use. And trust me, just taking a screenshot of the graph is not enough, because if you are thinking about taking photographs, unless you keep using it all the time, especially when you're reading papers or you're doing your own thesis or you're trying to write a paper or even analyzing a paper, reviewing a paper, you have to put this into practice on a daily basis. Otherwise, you will just forget it, right? So when there are two groups, you use the student t-test. When there are more than two groups, you use the ANOVA test. For categorical, it is simple. We use the chi-square test, right? So cat is chi. So categorical, any percentage, if you see it, we use the chi-square test. So again, this is the same thing in that ebook that I showed you. I'll show you that QR code again. This is all there, right? So if it's a continuous variable, if there are two groups, if it is normal distributed, use student t-test. If it's not, you use the rank sum or the Wilcoxon rank sum test. If it's more than two groups and it's normally distributed, we use the ANOVA. And this is something which I did not have space for in the previous infographic. So continuous variables more than two groups and it's not normally distributed, we use something called the Krusal-Wallis test. If it's categorical, it doesn't matter number of groups, 2 groups, 3 groups, 5 groups, right? We use the chi-square test. If the numbers are very small, say, endophthalmitis is like 0.1% in one group and 0.05% in the other group. Now, these are very small numbers. We use the Fisher exact, which is the modification of the chi-square test. So, once you do these tests, you get an output. You get the, so you will say mean IOP is 30 plus or minus 8 in one group and maybe say 28 plus or minus 7 in the other group. Okay, fine. So when you do these tests, you will get the output, which is called the p-value, right? So p-value really means the chance of, or it's a probability of this result happening by chance. Let me simplify it for you. So, suppose your p-value is 0.10, right? That means these results will happen by chance 10% of the times. So if you repeat this 100 times over, you will get the same result 90 times. You'll get a different result 10 times. So if the p-value is 0.40, right? So it is now different, right? So you'll get a different result by chance 40 times out of 100, while you'll get the same result 60 times out of 100. Now you're getting close to 50-50 chance, right? So then a p-value 0.10 is far better than getting a p-value of 0.40. Now, if p-value is 0.05, which is the cutoff, that means if you do the same experiment 100 times over, you will get the same result 95 out of 100 times. You're getting closer to being satisfied that, oh, this is real and this is not by chance, right? So that's how you interpret p-values. So let's come back to this example. The macular thickness was this. So do you think this is a continuous variable or do you think this is a categorical variable? That's the first question we need to answer. So this is mean and standard deviation. This is a continuous variable, right? Now, second thing is it normally distributed? So when you see this is the mean should be less than half, the standard deviation should be less than half the mean. Here you can clearly see the standard deviation is less than half the mean, right? So half of 480 is 240. This is 130, right? So this is normally distributed. So this is a continuous variable. It is normally distributed. There are two groups. So what test will you use to get a p-value? If I go back here, it's a continuous variable. There are two groups. It is normally distributed. We use the student t-test. So we'll use the student t-test. The output that we'll get is this p-value. Right? That's pretty much how we use these tests. Then example of a study from COVID, which is now published. So this is control group versus remdesivir group, which is an antiviral, and we may now have forgotten about it, but it was being rampantly used before. Right? So when you look at diabetes, there are 58 out of a 221 who had diabetes. It's 26%. Right? Now this is percentage. This is categorical. In the remdesivir group, 107 out of 262, that is 41% had diabetes. So 26% versus 41%. P-value 0.001. That's statistically significant. That means significantly more people in the remdesivir group had diabetes than control group, right? And this p-value is calculated using which test? Just think about it. So if you go back, so this is a categorical variable. Number of groups doesn't matter. right? So we use a chi-square test. So you get this p-value using the chi-square test. This is one example from a study using, comparing Ahmad glaucoma valve to the Orolab aqueous drainage implant. And when you see here, age, RD group is younger than the AGV group because p-value is significant. So what test do you think is used to calculate this p-value? It's a continuous variable. It's normally distributed. So this is student t-test. Now let's look at these significant values, right? So this is mean combined anti-glaucoma medications. It is more in the RD group, and mean oral again is more in the RD group, right? So RD group seems to be significantly younger and with significantly higher intraocular pressures at baseline, right? So then can you say that, oh, failure is more in RD? May not be, right? Because they were, we know that younger people fail more. And, if the glaucoma is far severe, then the chances of failure are also more. Right? So I'm using a lot of glaucoma examples because we have a lot of glaucoma specialists amongst us. So, so just, but then that example is not important. What is important for today's session is, understanding these p-values and, how to interpret all of that. Once we do that, second is, this was, comparison between or differences between variables. Second is correlations between variables, so which we are not really seeing because we don't use it a lot, and, it does not really change a lot of the interpretations. The third thing that we look at, and we won't go too much into details because I'll overshoot time, but it's called regression, right? So regression is what we use for causality. Remember, we started with the previous example of causality. So regression can be of 4 types based on your outcome variable. If your outcome variable is continuous variable, you will use something called linear regression. If your outcome is a categorical, then we use something called logistic regression. Output is called odds ratios, and we can have a whole session on odds ratios. If your outputs is counts data, something like number of steps in a day or something like that, we use something called Poisson regression. And if your output is time dependent, it's continuous, it's categorical, but it's time dependent. So how soon did failure happen, right? So that's called survival analysis or survival data, where time is important. So chance of recurrent retinal detachment over time or chance of trabeculectomy failure over time, right? So you want to maybe both procedures have the same, say 30% failure rate, but one procedure fails at say 8th or 9th month and reaches 30%. The other fails at about 6th or 7th year. And that's a huge difference, right? So if you just talk about, 30% in both groups, then it's going to miss a lot, right? You're going to miss that significant point of time. So if time is important, we use survival data, and that regression is called Cox proportional hazards analysis. So what regression really is doing is telling us whether there is causality between one and the other. Now remember that if there is dyslipidemia and there is glaucoma as the outcome, which is a categorical variable where you will use logistic regression, there are many things which can poke their head or nose into it. Some like age will pull that relationship towards glaucoma because the older the patients, the more risk of glaucoma. There are some which will pull that relationship against glaucoma happening. Some which will butt from top, pushing that relationship down. There are some which will push from down, pushing the relationship up, right? So there is a lot of tug by different variables. So, so when we have that one main driver variable or the influencer variable and the one outcome variable, all these others are together called confounders, right? So how can we adjust for the effect of confounders and then say there is effect of one over the other, or there is causality? That is what regression does. It helps us neutralize the effect of confounders amongst others. So an example of continuous variable as an outcome and linear regression is all your regression formulas for IOL power calculation. So your IOL power is a continuous variable, right? 20, 21, 22, 23, up to much higher and sometimes much lower as well, right? So it's a continuous variable. And these formulas, which are called regression formulas, typically they are called regression formulas for a reason, because they are based on linear regressions. And the commonest formula we use is the SRK and SRKT, right? And then there are theoretical formulas like the Barrett's and others. So that is an example of a linear regression, which we use almost every day in our lives. Logistic regression, like I said, outputs is odds ratios, and we won't have much time to go into details of these, but you should know that the 3 main types of analysis is differences, correlations, and regressions. So this is that ebook which I was talking to you before. You can just scan it and perhaps take a look at, pretty much everything that I've spoken now. It's about 5 or 6 pages, but it's all succinct and you can, get information out of that, right? And also now again, try and take this quiz and see how much you've improved so that, you know whether all of this has made sense to you. And you can take a look at, the Research Academy website as well. And, there's a lot of things happening on the website, and take a look at all of those. So try and broaden your research horizons right from your residency days so that, it'll help you going ahead. So thank you so much. And if you have questions, I can take them.
Thank you, Dr. Sunny. That was excellent. Like, I should say that every resident should spend a full day with him. So much to learn, and he's an excellent orator and a very good teacher. When every time I listen to him, I learn something more and more. And he has really made statistics so easy and so interesting for all of us.
Thank you.
So,
Questions?
Dr. Karan, he is a blazing gun, young ophthalmologist. Any inputs from your end?
So it was a wonderful lecture as always. And I would say I've had the privilege of learning from Sir physically. And we published our my first international paper, or it was an image actually put together. So thank you, sir, for that. Sir is always there guiding me. And this lecture was nothing but awesome. So, sir, one question I have is how much knowledge should young ophthalmologists or young researchers have in terms of the softwares like that, the SPSS software or that? So, how much basic knowledge is sufficient, or should you have a little bit more depth about it?
Yeah, I think, Karan, that's a great question. And so I would say that you don't have to know anything, because there are a lot of AI interfaces now which will help you do this. So if you want to learn a software, you need to learn its language, and that language is called syntax. So if you want to learn SPSS properly, you need to talk to SPSS in its own language. That's, so, or you learn SAS or Stata. So I use all of these. So learning that language is a big pain, and therefore it's difficult to converse with that software, right? So today you have a free software which is most powerful. There are two free software. One is called R, just the letter R, and the other is called Python. These are analytic softwares. And then you have AI, which are, they are actually writing code. You ask the AI in your own language, English, and then it will ask the software. You upload your data, you ask the AI will ask the software, it will intervene between you. It's almost like talking to a statistician. So you just upload your Excel sheet, which has to be made well. And then you can ask the AI, "Why, what was the mean macular thickness of this group at 3 months versus that group at 3 months? Show me the mean of both the groups and show me a p-value." And it will do the statistics. It will tell you what are the means, what are the test I have used, the student t-test, and this is the p-value I've gotten. Right. So then, but then knowing these basics will help you write the right prompt to that AI. That's pretty much where we are headed. So if you know these basics, that's pretty much what we need to know. So if you download that ebook and go through that, it will help you write the prompt to the AI. So that's, so you really need not know a lot. And please abandon SPSS, SAS and other things. So, R is the way to go. And then there are a lot of softwares which you can explore.
Is the R software freely available? Because
R-
everyone uses the R or Python, like
R The R interface is called R Studio, which is a little bit easier than actually coding into R directly. Right. So R Studio is there. So what you can, if you, all the other software that I said are paid software. So what you can actually do is you can ask ChatGPT for an R script, upload your data into R Studio, and then use that script and copy paste into that, because you don't know the code. If you knew the code, obviously you could make it better. But then if you don't know the code, which is quite complex, frankly, the R syntax is complex. So, so I would not really go into R Studio now. I would straight away go and open a software which liaisons between you and R codes. And then, it just does the whole thing.
So I'll take this question a little bit further, like with the AI that is coming up, as you were saying. So ChatGPT, Apurva is messaging on the on the box as well. So how do you think is it a challenge or is it a boon for researchers and reviewers? Because it does make things much easy, So what are your comments on it?
So there are many softwares now actually. So ChatGPT, so we are going to go into an era where softwares are going to be specific for a particular task. So ChatGPT is all and sundry. If you ask it about Donald Trump, it'll tell you. If you ask it a p-value, it'll tell you. So it is all and sundry. But then people are now actually using that ChatGPT and training it in their own way to do statistics. So so there's something called APIs. API. So they'll use the ChatGPT API and they'll train that to do statistics. So there are plenty of softwares. You can just look at Google and ask it, and you'll. So the one I use is called Julius AI. It's really nice, but there are plenty like that out there. So it's easy to use.
So Karan, we have a young researcher with you already, and that's like a welcome addition to the panel. So I had the opportunity of attending your AI in statistics lecture that you take, and that was really very well presented, of course, and added so much of depth to how we can use different versions of AI platforms for doing statistics.
Right.
So I think we have overshot our time today, and I would request Dr. Kasturi to conclude this session with her remarks.
So once again, thank you all of you for joining us today in this very enriching session. And it has been a real privilege for all of us to listen and to learn so much from all the insightful discussion, and especially from both the faculty, like both the esteemed faculty. Like we have both the lectures went of so much, and I am sure that every one of us have learned a lot from both the lectures. Very heartfelt thanks to all the chairperson, Dr. Usha, and to my dear moderators, Dr. Parul and Dr. Shubhav, and both the young panelists, Dr. Apurva and Dr. Karan, and also to every participant being present here for all their valuable time and active engagement. So with this, we thank you again. And next Thursday, we have got one more session on research. And the main speakers will be Dr. Namrata Sharma, and second speaker will be Dr. Sushmita Koshik from PJ Chandigarh. So I request Dr. Parul and Dr. Shubham to moderate the session. And as usual, Dr. Usha will be the chairperson. And I look forward to having all of you for the next session too. Thank you so much.
Thank you. Have a wonderful evening.
Thank you.
Thank you, everyone. Thank you.